Hi everyone, this is Neil Writer, also known as the Wax Whisperer. Thank you for tuning into my latest video. This is probably one of the most interesting, if not the most interesting cases I've performed. The gentleman had a mastoidectomy as a child. So a mastoidectomy is when the mastoid bone, which is the bone posteriorly of the ear canal behind the ear, is surgically removed. The mastoid bone is a honeycomb structure and it's full of air pockets. And if you have a middle ear infection, for example, the middle ear discharge can get absorbed by the mastoid bone, and the mastoid bone then gets infected, and it's called mastoiditis. If mastoiditis is left untreated, it can lead to serious health conditions such as a blood clot, brain abscess, or even meningitis. So the surgeon removed the mastoid bone. Then he also mentioned to me about 8 years ago, he had a secondary surgery, but he wasn't sure what it was. And we later discovered what it was and what happened. So when you've got a mastoid cavity, it's an enlarged, obviously they drill out the bone, the ear canal becomes enlarged, and it makes it more difficult for earwax and keratin to naturally migrate out of the ear. And the people with mastoid cavities generally, obviously upon review, constant review from ENT, have their ears cleaned out every maybe 3 to 6 or even 12 months, depending upon how quickly they secrete keratin and wax. And it's vitally important, if you've got a mastoid cavity, you do keep the ear as clear as possible from wax and keratin dead skin, because if that gets infected and you're having to then remove further bone from the ear, which is something you want to avoid. People with mastoid cavities also have to avoid water entering the ear, because we just want to minimize the risk of infection. So the patient normally would have routine NHS ENT appointments, but because of lockdown, the backlog, he was struggling to get himself booked in. So he found me on YouTube, and he came in yesterday. And so this is the left ear, and you saw at the beginning the wax was rock solid. I went in with the Zollner suction probe, but if I had live audio, you would hear a ping. It was that hard when I made contact with it. So what I've now done is used a combination of an ear hook, trying to release this wax from the canal wall. So the canal wall laterally near the entrance, it's got the normal shape. You can see it there on the right hand side, it's quite pink, but during the procedure you'll see the mastoid cavity. It's a hidden cave, and it was really fascinating removing the wax and keratin from this cave, as you will see yourself. So we just use some forceps. The wax is really hard and dry and crusted. So at the entrance of the ear canal, we've managed to clear all that. And you can see it's an abnormal ear there. That's not what an ear canal should look like. All the landmarks that we typically identify the eardrum with are really non-distinguishable. So when the wax is really dry and crusty, using instruments like forceps and ear hooks and Jobson horns really come into their own. So we've got a bit of dead skin there. You know that skin by the colour, and we just peel that off. So you guys will have to watch the entire video to see the surprise in this video, in this particular procedure. The surprise element comes right at the end, and you've probably seen by the thumbnail, there's obviously more going on here than meets the eye. Prior to the big surprise, you will also soon enough see a hidden cavity. So as I said, the mastoid cavity, the bone's drilled out, it enlarges the ear canal, and he's got here, you'll see a bit later on, a hidden cave, and we're removing chunks and chunks of wax out of this hidden cave. And that's the whole idea. That's why he attends ENT regularly, usually. So we've got this wax quite medially. It's on the posterior canal wall. It's stuck there, and it just looked like a normal piece of dry wax. A bit of skin maybe there where it's attached to the canal wall, and just trying to prise this out. You can see, you can't see anything else at the moment. I'm just using some forceps trying to remove it. The patient was comfortable throughout. He did find at times when I was at this point of the procedure, I found it slightly uncomfortable. And sometimes when you can see the wax is attached to some dead keratin, and when you're peeling keratin off the canal wall, it can be slightly uncomfortable at times. Sorry about that, guys. I forgot to edit this black bit out when I just came out of the ear. I do apologise. So I'm just going in with the forceps again. I'm just trying to get a grip on it. I'm just trying to pull this out. You can see it's adhered to some skin, and it's similar to the wax, more laterally. You do have to work the skin off as well to remove dry wax. And we just peel off a chunk of wax there and some dead skin. You can see that skin there, it's just hanging loose on the posterior canal on the right hand side. There's some wax at the roof of the ear canal. As I said, this patient's ear canal is extremely enlarged because of the surgery. So I'm just going back in. I was just evaluating the situation there. Just want to go back in and try and get this dry wax that's attached to some keratin. And it's just in front of the eardrum. Now the eardrum obviously doesn't look normal because of all the surgery. Again, I apologise for this blackout. So I've decided just to see if I can remove this with a Zollner suction probe. It's got a fine end attached. I'm just trying to loosen that keratin. That's where the wax was attached to. So if you sometimes remove that keratin, it will kind of loosen it. And again, it just looks quite innocuous. When you have people with mastoid cavities, you just sometimes have to be careful because sometimes some of the middle ear structures can be exposed. So you're going to just be, very delicate when you're working with a mastoid cavity. I've just got a suction grip at the top part superiorly where the dry skin is. I'm just peeling that off. You can see it's coming down. And you can see there's a tail of skin there that's adjacent to the eardrum. I'm just being very delicate here. I don't want to make it uncomfortable for the patient. I'm just going back in just to see if I can use the forceps. Now that I've detached some of the skin, I'm just getting a grip there, you can see, but it's just flaked off. So I think at that stage I decided to leave that and come back to it. So I'm just trying to get this dry wax and a bit of dead skin off the roof of the ear canal. And you'll see in a moment the cave appearing, so do bear with me. So again, just tried an ear hook, wasn't really effective, gone in with crocodile forceps. And because it's dry, when it's dry, sometimes I listen to read some of the comments, or why don't you use or the wax is really soft and gooey. Why don't you need to be you pick the right tool for the right job and the right patient. Sometimes patients don't like the look of some instruments, and they get really frightened when you kind of say, well, I'm going to try and remove the wax using this instrument, and they prefer you not to. So although sometimes on videos people think, well, why don't you use this instrument, that instrument? Well, it's the most obvious reason, because it's not the right instrument for the right piece of wax, based on the consistency of the wax, the location, if it's on the canal wall, for example, if it's on the bony canal wall. And sometimes we try and avoid it because patients get really nervous and they don't want you to use it. So now we're working on this hidden cave. I can see there's a bit of a crater. You can see there is a bit of a cave there. You can see a bit of wax, and it's kind of embedded within the canal wall. Wasn't obviously, it's the first time I've seen the patient, so I wasn't sure how expanded this cave was, but it was a lot more expanded than I initially believed. So I'm just using a bit of, again, suction here just to see if I can loosen it, just a little wriggle. So sometimes if we loosen some of this dead skin, just gentle wriggles, we can then go in afterwards with some other instruments, or sometimes it just peels the skin off and the wax that's attached to the skin also comes off easier. And again, we're just going to be careful when you're entering a mastoid cavity. So you could have some of the middle ear structures exposed, certain nerves, quarter tympani, for example, as well. So you're just going to be very cautious. You don't want to be pulling at things and removing things that could cause other issues. And you can see that you can just about see how the depth of this cave is beginning to become a bit more obvious now. You can see in the background where the cave is on the right hand side of the Zollner suction probe, there's wax really deep in there, but I'm just getting this bit out here. Now again, I'm just tugging at the skin, gently just removing it. We don't want to put excessive force. Again, the patient was great. He's obviously had this procedure done a lot. He did mention at the end that he found, obviously coming to me, it was great. He found it really comfortable. At times in the past, he has found the procedure somewhat uncomfortable when he's been elsewhere, but that could just be, it could obviously be part of the technique, but it could also be in the past his ear was in a worse condition. But yeah, he was really happy that he found me, and he said from now on he's going to be coming privately every 3 to 6 months to get it cleaned here instead of waiting for the NHS, because he was very impressed. So we've got this wax which is at the top of the cave now. And you're just going to wriggle it through. So you've got this hole and you've got this big piece of wax. We just have to maneuver it, get it in the right position. Sometimes when you remove wax from out the ear canal, it's like moving furniture from one room to another through a door frame that's smaller in width and in height, and you have to maneuver the piece of furniture in a certain way to kind of get it through the door. And sometimes it's the same with wax, especially when it's hard wax, because if it's softer wax, you can pull it through and it will squash itself. You can manage to wriggle it out. When it's hard wax, you just have to manipulate it. So just using some forceps here, again, just gently, just getting a grip and pulling it forwards. It's a long tail of wax and keratin here that's really crusted. The patient's main symptoms, I should mention, obviously, apart from having his ears cleaned out regularly, he also felt his ear to be very heavy. It was a bit strange sensation for him, and you will a bit later discover why. And in fact, whilst I remove this wax from the cave, whilst you're watching that, I will start discussing what we removed. So people who have repeated miliary infections, and obviously we know this patient has because he's had his bone removed, the mastoid bone. They can also develop necrosis, so a disease of the middle ear bone. So there's 3 middle ear bones. You've got the hammer bone, which is what we call the malleus. You've got the anvil, which we call the incus, and you've got the stirrup, which we call the stapes. So when sounds hit the eardrum vibrates and it sets these bones off in motion like a pendulum. They swing backwards and forwards. And the last bone, the stapes, which almost looks like a horseshoe, it's connected to the oval window, which forms part of the organ of hearing, the cochlea. And when this stapes foot plate, so the horseshoe, goes backwards and forwards, it causes inner ear fluid, so fluid in the cochlea. There's 2 types of fluid, endolymph and perilymph, and they're of different polarities, different concentration gradients, which is required because then you can produce an action potential, an electrical signal, which is what sound basically is. It's converted into electrical signal back to the brain, which we then process as sound. So those bones play a vital role. They conduct sound through the middle ear. And if those bones are stiff, your eardrum becomes really tough and it will just reflect sound away. They can also become disarticulated or discontinued, so they're no longer connected to each other, so you're not getting any vibrations. So in this patient, the bones have become diseased and they were probably removed because they were diseased. And what the surgeon did is put what we call a titanium Torp. Torp stands for total ossicular replacement prosthesis. So it was a titanium structure which mimics the function of the bones, the middle ear bones, because the bones have been removed. So the surgeons were trying to get some conductive sound through the ear canal, through the eardrum to reach the inner ear. So this Torp, you get a ball end which should be attached where the stapes is, and you'll see, and on the opposite end, it's almost like a saddle shape, and that should be resting behind the eardrum. So when the sound hits the eardrum, it sets this titanium structure in motion, so to replicate the function of the ossicles, the middle ear bones. And they usually put a bit of a graft, a cartilage graft, underneath the eardrum, so that the saddle end can rest against it. Occasionally though, and here we are, this is that titanium Torp. Occasionally, it's quite rare, this Torp can become loose, it can migrate, and I was speaking to my colleague Mr. Darius Rajali about this yesterday after I showed him the video, and he says it can happen. Foreign bodies in the ear have this willingness and wantingness to migrate out of the ear. So this Torp it was no longer functional. It had become detached, and the saddle end had actually protruded out of the eardrum. And that can happen just naturally. It can just migrate, it can puncture through the eardrum. Sometimes patients don't even feel the pain. Or it could have been the patient developed an ear infection, caused a perforation, and this Torp had just become lodged and loose, and half of it came out the eardrum, and the eardrum sealed itself. And you can see it was completely concealed by that wax. And it was only when I put the ear hook in and I pulled it out, you can see the red bit, that's some granulation tissue, some bruising there, and that's where the ball end came out. So this was completely, it needed to be removed. The surgeon who I spoke to, Mr. Rajali, says, well, you've saved us a job, because, but titanium it is inert, so it wouldn't have caused an infection as such. But eventually that would have had to be removed. So he was thanking me really, well, you've done a good job. But again, with mastoids, you do have to be very careful when you see kind of these structures. And the patient himself, when I removed that, was absolutely no pain. I actually called him half an hour ago before loading the video, just to get an update from him, and he feels great now. He feels his ear to be so much lighter. He's very grateful. And I just wanted to explain to him what surgery was, because he wasn't sure what he had done. I hope you enjoyed that video, guys. Yeah, very interesting and challenging. And if this is the first time you're watching me on YouTube, please do subscribe, press the bell icon so you'll get notified as and when I upload new videos. If you're on Facebook, please do leave, again, similarly, like, follow the page, leave a comment. And if you feel like leaving some comments, I generally don't try and respond to comments. There's too many comments, and some of the comments and some of the trolls are just atrocious. So unfortunately, I sometimes just with a quick glance, I do scan through the comments, but some of them, it's put me off actually reading them in full. Because some of the comments are just ridiculous from some of the trolls. But anyway, have a great weekend, guys, and I'll upload some new videos soon. Thank you. Bye.